from medicine or weight loss medicine or weight loss clinics as a sort of like, let's not shame the patient so that they'll come in and get their body size treated as a disease. Yeah, all right. So, oh yeah, there you are. Yes, thank you. Okay.
Press the button. Press. Yeah.
Okay. Okay. Whew, a little sweaty. All right. Anti-fat bias. So anti-fat bias negatively affects people across the size spectrum. And I think that's important. It's across the size spectrum. And body size and BMI category are not synonymous with health. We will discuss that further on in the conversation. This assumption can lead to misdiagnosis, praise of unhealthy behaviors, and increased rates of mental illness. Okay. A little more terms and then I promise we'll move on. Implicit versus explicit biases. So we talked about biases and we talked about how biases lead to stigma. Stigma leads to discrimination. And I think that's an important thing to think about. So implicit biases, these are, I like to think about like they're inside. So these are biases that we hold that we don't necessarily know that we have, that they're influenced by individual behavior without our clear awareness. They're created by exposures to stereotypes and misinformation, and they generally lead to microaggressions, and we'll sort of touch on that a little bit. So explicit biases, so these are intentional, deliberate, and conscious attitudes that influence our outward behavior. So these are things like, example here, physicians characterizing patients in larger bodies as lazy, lacking in self-control, dishonest, or non-compliant. A provider's communication, verbal and nonverbal, are all important factors that contribute to stigma and result in lower quality of care and negative health outcomes. So these are some examples. So what does this look like? What does explicit bias look like? This can look like being bullied for your size or shape, being stereotyped or doubted of your capabilities because of your size, having friends or family express concern for your health or without knowing your health status, medical or fitness personnel commenting or having conversations either not in front of or in front of patients, blaming them for their body size. This perpetuates shame and stigma. Implicit biases. This is attributing health problems to weight and or size. This is choosing or denying medications and treatments based on somebody's weight, and providers focusing on weight during medical appointments rather than the patient's chief complaint. Systemic oppression, the way that these biases show up, not being able to fit in seating areas in public spaces, inability to find clothes in your size in most stores, not having medical equipment. So not having medical equipment that fits your body, these are microaggressions. Not having a gown that fully covers your body, or not having a blood pressure that can accurately read your blood pressure, or having treatment tables that are stable or able to accommodate all size bodies. And we also see this as BMI cutoffs for fertility, OB, orthopedic, gender affirming, and plastic surgery, and higher cost of size inclusive clothing.
And I think one aspect too that's really important is the implicit bias can also be internalized. So a lot of times patients will come in and say, they're like, oh, well, it's just because of my weight that I have this thing, without knowing that there's other things that they can actually start to shift and change that aren't actually due to their weight. So it is that internal aspect too, and that internal blaming.
Yeah, that internalized weight bias. So what is diet culture? I feel like this is kind of like a hot term. I don't know if I can call a hot term, but a term that we're hearing quite a bit these days. And so what does that mean? And This is a quote from Christy Harrison. She's a registered dietitian, and she sort of summed it up, I think, really in a nice way. And it's a system of beliefs that equates a thin ideal with health and morality. It idealizes certain body types, sizes, and shapes. It demonizes certain ways of eating while uplifting others, and it is a culture that convinces you of your inadequacy and encourages you to spend your time, money, and energy to obtain the ideal. It is a culture of oppressing those who do not fit into this ideal. So, what is thin privilege? So, recognition of thin privilege. And this is something that can be sort of one of those topics like that can feel uncomfortable or whatnot. But so privilege is when you think something isn't a problem because it doesn't directly affect you. This means that your everyday life has not been more difficult because of the size of your body. You move freely. You get respectful health care. You don't have to think about being worried about going to the doctor or being worried about going somewhere and not being able to fit in a seat or being not getting paid as much as your smaller size peers. This looks like acceptance in fitness and outdoor settings and autonomy around food choices and having accurate portrayal in media and society. So the harms of thin privilege, very similar to the harms of weight bias because they kind of go hand in hand. Lack of access to care for fat and thin bodies, being praised for weight loss, body change, and increased risk of developing disordered eating and exercise habits. And I also just want to say that, so having thin privilege doesn't mean that you've never had any body image issues or that you've never struggled with disordered eating or that you've never been bullied or shamed for your size. You can have thin privilege and also hate your body. Having thin privilege also does not mean that you are in a straight size body. And as we discussed before, straight size is being in size 0 to 14, being able to find clothes in any store. It also doesn't mean that you haven't experienced discrimination in other areas, such as race, sexuality, class. Having thin privilege doesn't even mean that you feel thin or that you haven't worked hard. And in fact, most people, I'd wager, the majority of people never feel thin, even those with thin privilege. So,
I would even say one aspect too is I think that granted the 90s were harmful for everyone and we're not going back there, we're just going to stay at that right now, but I think too as we've kind of shifted into this more like muscular aspect too, it's more of just like privilege and whatever is in vogue at the moment, which is typically not fat bodies unless we go way back to like the 1800s or things like that. So just also stating that too, you may not be thin, but
right. Yeah, and to that point, so how did we get here? So why are we so anti-fat? And so fat bodies were idealized as far back as about 25,000 years ago. And as we have evolved, our bodies have changed. Height, weight, ability, skin color, all of these things. And this is a pretty big topic. And again, one of those things that we could have and plan to have much longer discussions about. But just some things to think about. This is some information from, this is a Black author, Sabrina Strings. She's a researcher and a professor. And she has this book, Fearing the Black Body. And she talks a lot about the 18th century slave trade began the classification of bodies. Black and fat bodies were thought to be impure, gluttonous, and overindulgent. And this is sort of when the pro-thin ideal came around, that a white woman could distance themselves from Blackness and represent their morals through dieting and self-restraint. So sort of this purity culture, abstinence, self-control kind of thing, kind of similar to diet culture. And so I think it's important to think about anti-fatness is rooted in anti-Blackness and white supremacy, as well as in misogyny and capitalism. And this quote here from her book is the conflation of obesity with racialized and colonialized communities is part of a long tradition of marking marginalized populations as diseased. And I also just want to point out that even though talking, obviously conversations about body size and things go back much further than the 18th century, like we talked about, just as when bodies were, what types of bodies are idealized and whatnot, but also just pointing out that not just Black bodies, but BIPOC, Black, Brown, Indigenous people of color tend to be more marginalized and kind of fall under this, how did we get here and why are we so anti-fat? So some of the things, what we've been taught, that weight equals health, that higher weights equal higher risks of non-communicable diseases, that weight is a byproduct of energy balance, calories in, calories out. Disease states are reversed or improved with weight loss, that we are in control of our weight and size, and that less is more. So just a few things. So kind of under we will sort of go ahead, we will talk about these things a little further on in the conversation, but we all have a genetic predisposition to be a certain size, which is called a set point weight. So there's great variation in the set point weight, and most people do not fall into the set point weight, this BMI category. So it's important to realize that there are over 900 genes that we know of so far that are that affect the size and shape of our bodies.
And also too, NCDs, if anyone doesn't know that term, non-communicable diseases in general. So things like type 2 diabetes, cardiovascular disease, stroke, things like that.
Alrighty, so we're going to talk a little bit about the harms of weight bias. So we talked at the beginning, sort of bias leads to stigma, stigma leads to discrimination. So it is illegal to discriminate against someone in healthcare due to their sexual identity, orientation, race, nationality, age, religion, sex, or disability. But it is legal to discriminate against somebody due to their weight. This weight-based discrimination leads to inequities in employment, healthcare, and education, and medical gatekeeping. So just a few things. Doctors spend less time with obese patients compared to patients portrayed as thin. These providers also rated the visit as a waste of time. Discrimination results in a 60% increase in mortality, even when controlling for other factors such as smoking, physical activity level, BMI, and self-reported health. And clinicians provide less health education to patients with higher BMI and are more reluctant to performing pelvic exams. So these are some BMI criteria for surgeries. So some common surgeries, total knee, BMI less than 35, breast reduction 30 to 35, gender affirming surgery less than 30 to 35. But bariatric surgery, which you could argue is just as complicated and dangerous as a surgery, you would not do unless the patient had a BMI over 35. So minis, you will hear the reason for this is that there's worse outcomes due to anesthesia and or healing post-operatively. But we routinely will do these surgeries otherwise on larger patients with higher BMI in the name of health. The withholding of a needed surgery becomes a tacit punishment for the perceived moral failure of fatness.
I think it's important to note too, some of these things can be like, besides the TKA, like these are things that we can somewhat reverse, as opposed to bariatric surgery where it's like, there are a lot of RDs in here, and Jess mentioned this too, where it's like, we're always looking at like, if we compromise the gut, then what do we have left, right? So I think it's important to note that for people who do have bariatric surgery, say it's a Roux-en-Y, they have to be on lifetime supplements for the rest of their life multiple times a day. They have to take a protein shake twice a day just to meet their needs so that their hair doesn't fall out and so that they're not getting severely malnourished. So I think it's really important to note that these individuals, they're like, we will treat you for your size and we don't care what your BMI is, but you won't get these other surgeries that may actually really improve your life and quality of life. And there's metrics and aesthetically, there's multiple research papers, but aesthetically, there's a lot of research and metrics on how you can make it more safe for someone who has a larger body.
So discrimination is a barrier to care. So individuals in larger bodies report feeling burdensome to the provider. They'll put off preventative care such as cervical cancer screening, breast exams, and routine labs due to shame, discomfort, and embarrassment, and avoid medical care due to fear of judgment and shame from providers, and avoiding care due to the dread of being weighed. So weight bias in health settings. So medical providers are the most frequent source of anti-fat bias. 52% of US women state that their weight has been a barrier to receiving appropriate health care. Weight stigma is an independent health risk factor for disease, even when controlling for BMI. And weight stigma and weight discrimination cause a twofold increase in risk of high allostatic load, which is a cumulative stress on all body systems. Weight discrimination and internalized bias reduces physical activity and enjoyment in adults and adolescents. And these types of biases and discrimination engage the HPA axis, increasing risks of hypertension and cardiovascular disease. An elevation in cortisol drives food consumption and sensitizes the food reward system. And so these are all sort of the physical things that we can see happening, that this increased bias and stigma leads to these increased stress, shame, and stigma, which all lead to having these negative outcomes on our health. And these implicit and explicit biases of healthcare and fitness professionals directly relates to negative health outcomes and creates a significant barrier to access to care and health-enhancing behaviors. So I think it's important to point out that as young as the age of 3, kids are starting to take in these messages. They're hearing it from their parents, their teachers, their doctors. This anti-fat bias and stigma, they're internalizing this. And this in children was pretty serious because this increases the prevalence of low self-esteem, lower academic test scores, and suicidal ideation. And starting a child on a diet, so those who are diet are 18 times more likely to develop an eating disorder, and eating disorders are one of the most deadly mental health illnesses. You think about if a kid is in the doctor's and they're having a discussion about this child's weight and they put them on a diet. A lot of the diets that are standardly recommended are restricted diets that would actually be considered diseating or disordered eating behaviors in a patient in a normal or a straight size body. And so I think it's just important to think about. So we think a large part of this is that because we believe that weight stigma and shame can motivate people to lose weight, that sort of makes the behavior okay. But in reality, this stigma is harmful and actually has the opposite effect and is harmful both to emotional and physical health.
Yes.
Yeah.
I just want to jump in also. Can I just chime in and say about those last 2 slides because of the mental health component that we pointed out with kids, but on the previous slide with adults coming in for care, whatever the setting, that mental health component also, the spiraling out and the triggering for more increased anxiety, depression, and suicidal ideation is so intertwined with the whole conversation that they should hopefully feel safe with their healthcare provider. However, because of everything you said, that mental health spiral also is one of the negative outcomes.
Yeah, thank you. I just want to take a minute and talk about research bias. So anti-fat bias undermines or is baked into the way that we think about health. And so what I mean by this is that anti-fat bias is so it's science that we rely on to tell us that fat is being bad, or that being fat is bad, or that being fat might be a disease is based on is biased to start with. This study here, this is the study that was responsible for the FDA approving liraglutide as a treatment for weight loss. Over on the left here, these are the conflicts of interest disclosures, and this is only a third of those disclosures. And normally, if you're reading a journal or if you're looking at research, conflict of interest disclosures are usually like a sentence or two. And this, so again, is only a third. And highlighted is every time that Novo Nordisk is listed. Novo Nordisk makes liraglutide. So on the left, you'll see the author whose name is highlighted in red. This author is an employee of Novo Nordisk. So they participated in the study concept, design, acquisition, analysis, interpretation of data, and the drafting of the manuscript and the statistical analysis, and they supervised the study. So I think it's important to it's important to just to look at what we are relying on when it comes to the research when it comes to weight loss and anti-fat bias. And the current research is focused on shrinking bodies, not caring for them, and this creates barriers to care, barriers to treatment, and decreases patient quality of life. And with that, I'm going to pass it over to Abby.
Cool. And I think even too in research bias, one thing to remember is that not only who's paying for it and who's studying it, but also thinking about also following it definitely within the pharmaceutical industry of like who's gaining money from this, right? And so there's a lot of things that we have a lot of data around weight stigma, why it's harmful to practice intentional weight loss, but we also don't have a lot of research on how to actually care for people in fat bodies. So even thinking of PT world, if someone comes in with in a fat body, we may not have the diagnostic exams to understand how do we find their bony processes, right? So how do we actually understand to diagnose this individual? I think even when it comes to overall, like anesthesia, things like that, we don't have the research because no one's funding it of how to care for 40% of our population. Kind of a big deal, right? They're just trying to sell prescriptions. So let's dive into the research because we're all nerds in here to an extent. So this is really fascinating. This is kind of goes back to like that simple graph that was on the other slide of that we think always, and we're always told from the beginning that a higher weight is going to increase your disease risk, right? We're told that all the time. That's what every research paper says generally. So this is a really fascinating research study by FLG. She got a ton of kickback from this as well. She was discriminated highly within the scientific community because she was just basically saying like, hey, actually the data that we're using isn't actually that significant. So they were looking at HR, which is a hazard ratio. So basically just mortality rate. You can think of it that way. There's a bunch of different markers and things that will go into this to determine this rate, but it's just what's your risk of dying. And so when we actually look at this, the lowest mortality rate is at a BMI of 27, which is considered technically overweight, right? Which is kind of fascinating. Specifically, the older that we get, it's actually more health protective to have a higher BMI as opposed to a lower BMI. A BMI up to 37 or 38, or the obese class 1 or class 2, there's multiple different obese classes, has the same HR ratios for mortality rate as someone with a BMI of 21. So I think specifically too, when we're thinking of like, oh, well, this person's BMI class 2, we should really be concerned about their health. It's like, well, are we concerned about the health of someone who has a BMI of 21? Not as much, right? Even thinking too, for those who are in the hospital and in healthcare, we all see like the BMI at the very top of the chart, right? Nurses, all of you are great, but sometimes those BMIs are wrong. And so I think even in that initial bias that we're going around screening a patient of looking at, oh, well, this person has a BMI of 38, like, okay, how hard is my day going to be, right? That's typically the association, at least I have found historically. And so even knowing that like that doesn't inherently mean that this is going to change or shift your care, and nor should it. The mortality rate for normal BMI, which is 18.5, is equal to those with a BMI of 39, which is fascinating. So technically BMI of 18.5 or BMI of 18.4 and lower is considered underweight, but 18.5 and above, not all the way above, but is going to be basically that deadly as someone who has a BMI of 39. So just thinking about that in context, again, specifically as individuals get older, the lower their BMI, actually the higher their mortality rate and risk is. Okay. So discrimination within employment and health insurance. So the context of this study basically was taking a bunch of NHANES data. So everyone knows what NHANES is, right?
I don't know.
Great. So the NHANES is a massive study where they go around, they actually have like an NHANES bus, and they're going around and taking some self-reported data and some measured data. How do they do this every 10 years? Every 2 years.
Yeah.
There you go. Every 2 years. So this was really fascinating because what they took was the blood pressure levels, triglyceride levels, cholesterol, glucose, insulin resistant, CRP. CRP is overall just like one of the inflammatory markers, one of the markers also for heart disease and your risk of heart disease. And then stratified these by their BMI category. There were over 40,000 adults in here. Only 2% of actually the studies that they were gathering in this met the criteria of it. So that's really fascinating as well. And so when we actually start to look at the findings of this, is we can start to see that actually when we look at this, so if you can't see in the back, there's 47 and 52%. They're classifying people as healthy or unhealthy. And this meant looking at all of their different lab values and biometric data. And so from here, we can see that it's basically a 50-50 split if you're healthy or unhealthy, if you're in an overweight BMI. Fascinating, right? Not typically what we would assume. Then when we start to look at the obese type 1, we have a 28% of mortality, or 28% of them were considered healthy versus the 71 unhealthy. But take that number, remember that 30%, 28, and then when you can start to look at here down at the normal weight, 30% of the normal weight individuals were considered unhealthy. Meaning that over 75,000 of the US adults are misclassified as healthy or unhealthy. And so this goes back to the point that looking at BMI, it harms everyone across the disease or size spectrum. And the reason why is because a lot of people say you're coming in a thin body or a small body or socially acceptable body. A lot of times, I mean, I've been in the case before where like, I don't get metrics taken or things like that. Kind of a doctor just goes to run in the mill of like, all right, what's wrong? All right, cool. Like, great. Where a lot of things could go misdiagnosed, as opposed to someone who's in a larger body or fat body, maybe their hip hurts and they're like, well, depending on your medical system, you may have a pop-up that says, I have to educate this person on losing weight. So first and foremost, we're starting with that, starting with the stigmatizing space. Second, we aren't even listening to what their chief complaint is, and we're just educating them about things that they probably didn't even ask for, and we're not even asking for consent in those scenarios as well. And so we'll talk about asking for consent. But I just think it's really fascinating too that, again, it's harmful for those in larger bodies, but it's also harmful for those who are in smaller bodies as well, because we're missing a lot of things. Any questions on that?
It's crazy.
Isn't it surprising?
The 30% on both spectrums.
Yeah, like within 2 percentage points, like kind of wild.
Yeah.
On the previous slide when they were looking at mortality, was it all-cause mortality or mortality from non-communicable disease, or what was
It was non-communicable diseases.
Okay.
Yeah. So all of the metrics we're basically looking at, when we look at here, all the metrics they looked at were like blood pressure, triglyceride levels. They weren't looking at like, mortality through like car accidents or things like that or trauma. Sweet.
Was there any adjusting for confounders on this as far as metabolic status? Because I think it's interesting to think about, are we considering the impact of weight stigma?
Well,
when
you know, we're
talking
gonna
about-
get there.
How do you-
Yeah, we're gonna get
My
there.
bad.
Well, good question.
Totally. So I think this is too, just like in it, my goal. And so this is really fascinating to look at too, like when we think about a weight-centric health model. So as medical providers, people are coming to us for help, right? We're not trying to harm them, but typically in a weight-centric place, we are taking weight as the main aspect that is going to impact everything else, right? And so a provider goal may be weight loss to improve A1C, CRP, blood pressure, decrease their BMI to get them in a healthy range and normal range, and then decrease overall markers and risk. As for the patient's goals, which first and foremost, they probably weren't necessarily asked what their goals were, but it's overall like, hey, I want to improve my health so I have energy to like go play with my kids after work. Like I want to not have pain when I'm walking up the stairs. Or I want to be able to increase my fitness so I can do X, Y, and Z. And I also want social acceptance. I think that's one aspect too. A lot of times when people come in my office, they're like, I want to lose weight. And I'm like, all right, let's break that down. What would the end result, what would you gain from that end result? Say you did theoretically lose weight. What would you gain? I'm like, well, I'd like have more energy. I'd sleep better. I would, I don't know. Yeah. Be able to play with my kids. I would be stronger. And I'm like, well, we could actually just look at getting stronger and not focusing on weight. And we can do those things without necessarily changing body shape or size. Also, I think when we think about this too, it's more intentional weight gain. We actually don't know what bodies are going to do when we increase their overall, like increase or maintain their caloric intake or get them out of restriction, or if they start moving more. We have no idea what they're going to do. There's actually some fascinating data too of like, there's a lot of people who actually gain weight in caloric restrictions and actually gain weight in response to movement. And so it's really looking at how do we just actually throw weight as really not the central piece of it and start to shift and change our metrics. Okay, so what this actually does is this actually increases weight cycling. We're going to talk about in a minute, so pinning it. It's going to increase overall mortality, stigma, discrimination, chronic illness, and typically increase BMI. Fascinating. So, just a little cycle of what this does. So when we even look at the HPA axis, so this is the hypothalamic pituitary adrenal axis. So this is basically like our endocrine stress response to things. So whenever we get stressed, this is also well documented in any sort of like bias or racism or trauma or things like that. That's also why anyone who's Black or brown is a higher risk of any sort of non-communicable disease than someone who's white. So what this will do, what stigma will do in this perpetuation of stigma, it's going to increase the risk of hypertension, overall cardiovascular disease. And these two stats are really fascinating, I think, to also put into context. So the probability of an obese individual of ever attaining a normal BMI is 0.8% for women and 0.4% for men. Like it's probably not going to happen. And again, this is because there's over 900 genes that are going to impact what our body shape and size looks like, plus also the other factors of environmental factors that we're experiencing and our DNA is experiencing through time. So when you start to look at epigenetics and things like that, all of this is deeply going to impact it. Then when you start to look at those who are classified as morbidly obese, the probability of even 5% weight reduction, I'll put that into context because what does that mean, is 14.2% for females and 12.5% for males. And what this actually means is a female who's like, I don't know, pretty standard size, 5'6", 250 pounds, might have a 14% chance of decreasing their body weight and lose a total of 12 pounds. Like when we think about that in context of like 247 minus 12 pounds, like that's probably not what the medical provider is actually thinking. That's not a whole lot of weight. And again, it's not even going to shift them into like a healthy category, big air quotes around healthy. And so I like to also think of it like this because the pharmaceutical drug industry has a huge impact on what we're actually researching if there was a drug that was less than 1% effective in treating the target condition, would it be approved? Probably not, right? I see a lot of heads saying no, but no, absolutely not. If I was like, hey, I have this drug that like really doesn't work, but like I want to like see if I can make some money, the FDA is like, absolutely not. Get out of here. So I think that's just a fascinating way to also think about too. Like we think weight loss is a health treatment and a really like it's one of the treatments that's like, oh, we can use this instead of medication, but it's like it doesn't work. And so we need to start to look at like what else do we do? This is a fascinating study by Gasser and Dr. Ngadi. They were two ASU professors. One is now at UVA, Ngadi is. And what they looked at was basically looking at fitness versus fatness. I want to also like have you all remember that like no one owes you their health, but in this context, we're looking at overall fitness markers and like the BMI overall. So here, this is just, again, like the futile weight loss cycle. So it's looking at desired weight loss, increased weight loss attempts, in order to reach that, increasing overall obesity prevalence here. So when we actually look at the incidence of obesity, it's increased threefold over the past 40 years, and so has dieting, right? Like we have way more diets than we have ever had before. And this is, again, part of like wellness culture, diet culture, all these different things, someone trying to make money. But it's important to note that both of these things have actually increased simultaneously and no one's actually gotten smaller, right? So it's probably not working. So we can start to see that also when there's failed weight loss attempts, it's not here, but there's a very tiny study that was done on The Biggest Loser. And so they've actually followed them for multiple years. It's 14, there's an N of 14. So we can take that into account. But basically they started to look at too, that overall their basal metabolic rate was lower than it was when they first went into these studies, and they ended up gaining all the weight back and even more because of the damage, the physiological damage of severe calorie restriction. When we start to look at this too, over like 50% of people have tried to lose weight in the last year. So half of your patients have, and know that this actually may impact your outcomes and their health markers. So this study was specifically looking at overall fitness versus fatness. And we're gonna start to look here at cardiorespiratory fitness. So what this is there's a few different ways we can test it. We can look at VO2 max, or we can do a max out on an incline treadmill. Basically, it's how we're going to test this thing. And so over here, you're going to see, for those of you who can't see in the back, the red lines are unfit, and the blue lines are those who, or the red lines are fit, the blue lines are unfit. And so what we can actually start to see is by, it's not necessarily the BMI or the weight that is increasing their risk here. It's actually looking at, when we start to see here, there's not a whole ton of increase in their overall all-cause mortality, but then also their cardiovascular disease mortality. So I think this is important to note too, that actually being fit and having some sort of movement, and we're not talking about like, I'm just gonna throw this out here, but like not like Flagstaff fit. We live in a pretty like orthorexic, fitness-centric space in Flagstaff, but this is basically meeting the very minimal requirements that's standardized by the American Heart Association, the American Diabetes Association, which is 150 minutes of moderate activity per week throughout multiple days. So not all at one time, but that's what they're testing. And that's what they're saying, is that these individuals who are fit walk 150 minutes at a moderately brisk pace a week. Like, again, not doing a whole ton. And so when we really start to look at this, we can look that, or we can see that the fitness aspect is going to be the main takeaway here, independent of BMI. And we're going to start to see a greater reduction in their overall mortality the more fit that they are. And also, we're going to see a higher risk in mortality the more that they try to actually intentionally lose weight. And this, again, is going to go towards weight cycling. There's a lot of physiological aspects. That's a whole kind of bigger topic that we could totally talk about. But now it's harmful, and it's going to increase their risk, and the perpetuation of that is going to be harmful as well.
Yeah, and just to add to that is that intentional weight loss over multiple studies, and has been looked at, that it's like you were saying, it's after 5 years after gaining back the time, but it's only 95%. That there's a 95% failure rate, and so if you had, it's just kind of going back to where you were talking about the 1%, if you had something, if you're gonna prescribe something to a patient that has a 5% success rate, then.
Yeah.
Yeah.
Totally. And so we can start to see here, it's like weight cycling is going to be associated with all of the things that also higher BMI is associated with, right? So higher risk of cardiovascular disease, actually higher risk, it's not on here, but higher risk of type 2 diabetes. And so is it actually the weight that we're consistently documenting in research, or is it the weight cycling because of the stigma that has been perpetuated that's actually increasing these individuals' risks? So that's what the study basically looked at. And so this is just a way to think about it too as a medical professional. It's like, if you could extend your lifespan by 5 good quality years, but that would shift your BMI category or would cause you to gain weight, would you do it? Right? If the answer is not yes, then it's like, cool, it's not about health, it's actually about appeasing social norms.
And being, not wanting to be stigmatized and all the things.
Mm-hmm. Yeah. And I think from a provider standpoint too, especially for a provider, like a lot of times our patients and clients are out there to please us. And so it's really like they are trying to do a good job. Generally, like no one wants to go to the doctor and be like, yeah, actually, like, screw you, like I didn't do anything most of the time. They actually want to be like, hey, I did a thing. And if we're setting this bar so high that no one can meet it, then they're probably not going to come back to us and they're probably going to cease seeking medical care as well. Okay, so what do we do, right? I've talked a lot about like, all right, not prescribing weight loss. So what do we do instead? First and foremost, we need to look at like, what are the social determinants of health? So these are economic stability, access to healthcare, education, neighborhood safety and environment, even thinking about like clean air. Those from BIPOC populations are more likely to live near freeways and near factories. So they're going to be at higher rates and risks for respiratory diseases as well. And also too, social and community connection and context. So when we start to look at overall like the education aspect of stigma, which we talked about, there's overall lower test scores for those who have experienced weight stigma than those who have not compared to it. So when we start to think about that, if education is going to impact the trajectory of someone's most likely economic stability later in life, possibly social connection. And so thinking about that, if they're, again, in kindergarten or preschool or in middle school and experiencing either bullying or experiencing some sort of weight stigma, they're less likely to apply themselves in school. They're less likely to show up and actually start to look at like getting higher test scores and seeing and making a difference in that sense. Also, again, less likely to seek care for discrimination, because if you go in and your doctor's like, well, you're lazy, you're non-compliant, you're probably not gonna go back, right? Which is also one aspect too, is cancer is typically diagnosed later, or like staged later for those who are in larger bodies because they refuse to seek care, because they're so terrified of just being told that their body's wrong.
And you go to the doctor and they don't believe you.
Or they don't believe you. Yep, they just tell you to lose weight
Yeah.
because that would solve everything. We've learned it doesn't. When we look here too, so BIPOC community and low-income populations are actually more at risk of being obese in a higher BMI category, and this is partially due to genetics. We have all evolved in a lot of different shapes and ways to adapt to the places that we've been. And again, BMI is not going to be something that we can study in this very white male population and say this is a really good metric for the entire world, right? So that's one aspect too, is that when we look at housing, they're going to have less safe environments in general. Also, they're probably not going to be able to have access to safe food in their neighborhoods. When you even look at food deserts, or what I even like to call food apartheid in general, there's going to be lack of access and also lack of space to walk or safe places to walk or even get general exercise. Social isolation, increasing mental health risks, so depression, anxiety, all of these things. Also, risk of suicidal ideation is going to go along with this. And then when we start to look at pay and discrimination in hiring, on average in the UK, someone who is in a larger body or an obese body or fat body gets paid on average about $2,500 less There hasn't been a study yet in the US that I'm aware of, but that was a pretty big study out of the UK, which is kind of fascinating too. Other things we need to think about as well is genetics, right? So genetics, epigenetics, how are all of these things playing together? Hormones in general, that's also why too, the aspect of just simply calories in, calories out, it's much more complex than that because our hormones, which I like to think of as a symphony, are going to be the things that dictate really how our body is utilizing and processing food, and in the background how it's really dictating if we don't have enough calories overall, what our body does, it slows down, so we move less, we do like less hand motions and things like that. So if we are in an underfed state, that's one aspect that will happen too. And when we start to look at overall like chronic illness, right? You're not going to be able to move as much if you have chronic illness. And then when we start to look at even like medications, there are medications that can increase weight gain and also start to shift and change our overall risk and health outcomes. Okay, so what do, right? First and foremost, we need to look at like what are our own biases. And I think that's really hard and it's really uncomfortable. It's not, and especially too, when like a lot of the George Floyd stuff came out, especially when you looked at privilege, like there were a lot of people who were really uncomfortable. And so this is kind of the same thing. It's uncomfortable, especially because everything we've ever learned as medical providers is very weight centric. So first and foremost, and because even thinking about like all of our media. So there was one slide on like a few back where it was talking about being accurately portrayed in media, right? So typically when there is a fat actor, actress, or someone in a movie, they're portrayed as mean or evil or lazy. They're never like given a key star role. So that's even too, when we look at representation, that matters a lot because that's that internalized stigma. If there's like a little kid running around, it's like we can't necessarily shouldn't try to change their body weight, but they think that, oh, I guess I'll just be mean and lazy, right? So that's an aspect as well. So first and foremost, we need to ask ourselves, what are our own biases? So do I make assumptions about other people's character, intelligence, success, or lifestyle based on their size? Am I comfortable working with people of all shapes and sizes? I would say actually a lot of people aren't. And as a dietitian in this shape or in this space, it can be sometimes really difficult. It took me a long time to be able to first and foremost say like, hey, I have a lot of thin privilege. I don't know what it's like to be in your body, but I can help hold a lot of space for that. And so it's even like being able to say that is a really vulnerable thing. But also, are you comfortable in the sense of being able to, do you have access to the equipment that you need? Do you have access to the markers that you need to be able to actually treat a patient well? Do I encourage and help promote healthful behavior change as opposed to just weight loss? And are you sensitive to their needs and concerns? So one big aspect in weight inclusive care is always asking for consent. So asking for consent of like, do you want to be weighed? Knowing that people can say no, and they're allowed to opt out of that. You can technically not really ever be weighed, or you can self-report if you want to. Generally for insurance purposes, you can put refuse in a clinical way to put it, but it's not the patient refusing, it's just, hey, I don't want to participate in this very stigmatizing thing.
Providing body autonomy. I mean,
Yep.
Patients.
Yep, every patient has autonomy over their body and their care. This is typically something that's in all of our ethics values as practitioners as well, that patients have body autonomy. So this is the way that I like to think about it, and we can share this because you probably all can't see this, but I like to think of this in 4 pillars. So first and foremost, looking at size inclusive space, like do we have armless chairs that aren't like really hard to get in and out of? Are they accessible for most people? Do we have, again, clothing, gowns, equipment that we need? And do we have, even thinking of like treatment tables, trait colors, wheelchairs, blood pressure cuffs, all of those different types of things. Even looking at whether it be in emergency care, like do we have a variety of like intubation sizes and trays for all people? Or even if someone who's working mostly in pediatrics, like do we have adult sizes because they may be bigger? Then we need to start to look at, first and foremost here, looking at consent and making your care patient focused, not provider focused. So it doesn't matter what you want for them, because it's not about you, it's about them. And so maybe you really want them to be able to walk around the block or something like that. Maybe they don't care. It's not your place to judge. So allow the patient to identify their own goals. What do they want to focus on and what do they want to gain out of their care? So is it maybe just not hurting as much? Again, they probably maybe don't want to ever go running, but would they rather just not have their knees hurt? I don't know. Looking at function, feeling, things like that, independent of weight or body size change. Asking for permission prior to weighing someone, but also even prior to like bringing up a topic. A lot of times in conversation, before I give my 2 cents, I'm like, hey, would you like my viewpoint on this, or would you like my opinion on this? And a lot of people are normally floored when I ask that. So asking, and also asking before educating. So instead of being like, oh, well, in my world, living in my world right now, fibrous foods are going to do X, Y, and Z. It's like, hey, would you like to maybe know something about your cholesterol that may help improve it so you may not have to get on a statin right now? Typically they're like, yeah, that sounds cool. So always asking before. Ask for consent prior to weighing. Offering blind weights. Weight should always be done, if you can, in your clinic in a private space. We've all been in clinics before where it's like in the hallway, right by the reception desk, and like maybe the people in the lobby can see. So if you have the ability to, of like, and if you have to weigh people, put it away. Always put it away in a private space. Ask them. They're allowed to refuse. And if someone asks you for a blind weight, has everyone ever heard of a blind weight before? Okay, so blind weight is basically you as the provider can know, but they don't want to know. This is typically for maybe someone in a larger body, also definitely for people who have had struggled with disordered eating and eating disorders, where a lot of times people do not want to know. And so that's an option if you really want to weigh someone and really need to, for whether it be a prescription medication, whatever it is. But what that looks like is either having them turn around or covering the weight so that they don't know, and then being very specific with MAs and other office personnel to not tell the patient. And don't tell them their BMI, because I had that recently where someone's like, yeah, I had a blind weight, but then they told me my BMI and I can figure that out. I'm like, great, cool. We're really just like trying to get you to eat a little bit more. Also thinking about aspects of looking at what documentation is sent home with the patient. Does it have their BMI and their weight listed on it? If they've asked for a blind weight, they don't want to know, so do not put it on it. Black it out, mark it out, do what you need to do, but make sure it's not going home with them. And this is really from a disordered eating space, and know that disordered eating and eating disorders do not just affect those in small bodies, they affect all bodies. Looking at now targeting stigma. So providing ethical and respectful care no matter the patient's body shape or size. Looking at screening for eating disorders regardless of body size. This is something that is not done. I don't think I've ever been screened for an eating disorder in a primary care situation. That'll be a topic that we will cover later on how to screen for those. And how do we start to even to, a lot of times, because this internalized weight stigma, a lot of times patients are going to come in with self-deprecating comments. So even looking from an aspect of like, it may be such a relief for a patient to like have that reframed of like, oh, wait, so me having knee pain may not be related to my weight. It's like, yeah, maybe, probably. There's a lot of other things we can do. And then looking at sustainable evidence-based care. Weight loss care and intentional weight loss is actually very risky. Again, it's going to increase non-communicable diseases, increase mortality rate. So it's actually very risky care. So how do we start to look at sustainable, lower risk care? We recognize that health is multifaceted and nuanced. So again, going back to the social determinants of health, we educate the patient on the disease process. I cannot tell you how many times I've had someone who's come in, who's had type 2 diabetes for a year, been diagnosed or things like that, and they've maybe been to multiple provider appointments, but they don't even know how it works in their body. They don't even know what diabetes does. They don't even know what possibly, like, what are things that they can do and what are aspects they can actually start to take metrics on. So maybe it's looking at providing like behavior care, looking at like, all right, can we look at tracking your overall blood sugars, like in the day, to make sure that you are making a sustainable evidence-based goal that's going to help decrease that disease risk in that process so that they're more aware. Looking at, again, actionable goals, BP monitoring, blood glucose checks, movement, nutrition, and overall self-care. Any questions on those? It's going to seem like a lot, but we can do a little bit at a time. All right, we're almost done. Oh, go ahead.
I was just gonna say, that handout that we have, has a lot, most of that and then more on it as well.
Mhm.
And we can make that available as well.
Yeah.
And if you didn't get the handout, it's in the back, you can get it.
So we need, how do we start to optimize the care? We need to look again that it's multifaceted, and that we often think, especially if we are in a medical system that isn't really focused around mental health or psychiatry or psychology, we typically treat the body from here down, right? And so it's looking at, we know that stigma is deeply impacting our physiology, and it's not just the way that we're moving our bodies and the things that we're doing. It is deeply also mental and psychosocial. So assessing, how do we start to assess the social determinants of health? We can first and foremost, before we educate a patient on like, well, you should be eating this, like, do they have access to food? First and foremost, right? You can ask some questions of like, where do you typically get your food? You know, that can be a really good way to get you to give you an idea of their economic status. Like, are they getting their food from Whole Foods, or is it typically from the pantry, like the food pantry or something like that? Making sure that they're connected and have support can also be a really good thing of like, who else is in the household with you? Who can help make sure that we are checking your blood pressure every day, you know, at a certain time? There's ways that we can start to really look at that connection as well. We can start to look at, do they have adequate safe space, and what economic barriers do they face, not only in their maybe medical care, but also just in general as well. So not only food, but also like thinking about prescriptions and things like that. Even asking about health insurance, that's also obviously, as we know, a big barrier to care for a lot of individuals too. Ask about small things that they can do, sleep, medication management, nutrition, all that. Again, instead of doing it in forms of like disease or in forms of weight loss, especially when it comes to nutrition, physical activity, because those are always like, oh, I want to lose weight. Great, we do these things. Not necessarily. We can talk about them in a lot of different ways that don't actually have to do with changing the shape and size of their body. Cool. Knowing that weight, again, is not a behavior. It's not something that we can necessarily change or have the power to change. All right, so hopefully now you know the harms of anti-fat bias and diet culture and even wellness culture across the size spectrum. We hopefully should understand that the weight normative paradigm is a little broken. And it sounds really hard, especially as a medical provider, because like we don't really get to dictate who's doing the research and who's doing all these things. But if we all can start to make change from a patient to patient standpoint and within our tiny healthcare systems of whether it's an office or a hospital, if we can start to look at destigmatizing, that can actually make a huge difference, not only on outcomes and stigma, but also hopefully in starting to really advocate for this shift in doing more research in these spaces. How do we actually care for 40% of our population? A weight neutral approach is going to be more ethical. It is definitely evidence-based. I think that's a lot of times people's friction area, especially in the medical field, of like, well, we have all this evidence that BMI does this. It's like, we actually have a lot of evidence that that's not necessarily the best way that we can care for people as well. Respecting a patient's always going to be the best thing that you can do, so that you can actually build that rapport and have a relationship and continue to be a part of their care. And it's going to uphold the overall principle of do no harm. Great. Cool. Again, you probably won't, like, at the end of this, be a professional at this, and you shouldn't have to feel like that, but hopefully participating in these conversations and educating yourselves can really be that first step. Okay. Questions? Anything? Yeah.
And I don't know if you can answer this now. I've been more curious about the research on like everybody's natural set point and trying to incorporate that into conversation with patients when they're referred for weight loss and stuff like that. That way you can defer just to, you know, other healthy lifestyles or whatever their interest is in the appointments.
Yeah, and so this is more of like some people's opinion. I don't love using set point theory because actually set point can change. So yes, we all have like a base kind of where we start at. A way to think about it too is that if we like generally look like our parents, like, or if we kind of have the same body shape or size, like we're probably going to continue to look like them in our family. And so I don't like using set point because it's very focused on weight and saying that this is where you should be, no matter what. And it's like we can actually see set points start to change depending on how much they're cycling through diets, how much stress they're putting on their body, whether it be physiological stress, but also even like more mental health stress as well, which impacts their physiology. So I really like to look at it of like, set point aside, we are all like made to be in kind of like given the bodies that we're given, and how do we start to look at what behaviors can we do to just improve health with taking just like set point and weight out of it.
Mhm.
Does that make sense?
Yeah.
Yeah. No, but like there's a lot of good data on set point theory as well, but know that it can change. It typically doesn't go down, but it can change.
Yeah.
Yeah.
And a lot of people just saying, oh, I want to go back to my pre-pregnancy weight, or I'm 65 and now I'm gaining weight. And it's like, that's okay. Your body's changing.
Yeah, and I think that's one aspect too as a medical provider, being like, hey, like our bodies have always changed. Like if we looked like our high school selves, like red flag. And so I think too for people, and for I think especially those who are like in maternal care and things like that, of recognizing, and I think coming into a place of like not only acceptance but also celebration of like, hey, how do we start to look at like all the things your body has done, you know, since then, and recognize of like your bones change, your like muscles change, and all of these different things will change through the birthing process. So it's really just like holding space for that and care, and recognizing that the societal aspects that we put on women of like bouncing back and things like that are just like really toxic. And I just tell my patients a lot, I'm like, I can't change society right now, but if we can slowly start to change our internalized thoughts and ideas, that's a big step forward. And like loving your body and accepting your body is actually like a pretty radical form of resistance.
Or even just not hating it.
Yeah, just not hating it. Yeah, you don't have to love it. No one's that. I like
toxic.
no.
Positivity.
Definitely not that. But I like to think of like neutrality as like if someone hates their body as like a -10 and body positive would be a +10. It's like, how do we get to like -2, maybe a 0, or like a +2 would be like a good day, you know? So it's like looking at how do we kind of look at function. That gets into a little bit of like an ableist conversation as well, but how do we look at function of how our body has shown up for us and things like that. Yeah. Any other questions? These are a lot of big topics.
And I was like, that could be
Yeah.
a whole conversation.
I find that like reframing conversations with patients is sometimes the hardest thing, because they've had this reinforced over and over and over. And if they come in and say, hey, I want to lose weight for XYZ, reframing that is tough. And I think it's possible if they're talking about health, or for me, it's pain or something like that. But how would you reframe it if somebody is like, I want to be able to fly in an airplane more comfortably, or fit in a chair like this more comfortably? I know the long-term answer is changing society,
Right.
but in that visit, how do you start to change? How do you start to not give them not give them no hope, but also not give them a plan and a goal that's not going to work?
Yeah.
I don't know if there's like a tension there.
Yeah, that's a really hard question, and I'll try to answer it to the best of my ability. For a lot of things, there's not a lot we can do as providers in that moment, right? But I think specifically when it does come to whether it be like just autonomy as a human, of if it is like airplane seating or something like that, it's like you can ask for a seat extender, and you can just ask a flight attendant so that you can actually safely fit within a seat, granted, depending on your size. We've all been in airplane seats that are uncomfortable, even for like straight size bodies, but like it can actually bruise people's bodies. So also too, once people are seated, someone in a larger body could ask if like, hey, is there like an extra seat somewhere there that I could have 2 or something like that. Southwest actually has a lot of really good policies around fat bodies. So that is a company that is kind of really working towards that, and they will reseat clients who are in larger bodies, so that they are more comfortable. But yeah, it's definitely too, when it comes to like, even like when we think about fat tax on things, it's like a lot of times people have to get 2 seats, which means that they're paying double
for the same flight, which means that they also may get to see their family less and may have less social connection. So there's a lot of aspects. I think there was recently a big survey or feedback thing to change the FAA standards of seat size. I don't know if that's still going on. Did you hear about that? Yeah, but it was, do you know what happened with it? Yeah, but it was basically people could like provide comments of like, hey, I think they should be this size, because it's not totally standardly regulated.
And just to add to that too, I mean, I think having conversations with patients, so they want to do it because of their health. And I think, educating, like, we don't have there's no way that I can recommend or prescribe safely intentional weight loss for you that does not result in harming your health. And so, having that conversation with them, framing those conversations, and really just, being vulnerable and being open, like, yes, you want to be able to fly on an airplane. You want to have these things easier, and
Whoa.
recognizing
I think that's you.
that they are gonna that you are willing to have that conversation with them and still not stigmatize them, and that it's where they can talk about it, and just educating and having those conversations too. So
I think a lot of times too, because they're like, well, I do want to change my body. And it's like, well, even when you were in a smaller body, did you feel better? Typically, no. I like to think of it as like, we can paint the outside of the house, but that doesn't mean the plumbing is better. So it's really looking at like, how do we start to focus on some of this body acceptance and neutrality space, but also really looking at too, like remembering that patients have autonomy. If they want to go on a diet, you can tell them they can do that and they have the right to do that. You just might not be the right provider for them, at least from a nutrition standpoint. That's typically what I think about. And then I'll often weigh like pros and cons of like, what about mental health and these things? And then it's a big conversation. But yeah.
I think too in that situation, just like educating on the lack of control over our body size. And sometimes you have to kind of be the barrier of bad news and hold space for that. But it is very confusing for patients when their primary care provider is telling a different story.
They're like, what?
Yeah.
Everything I've been told is a lie. And it's like,
My whole life
kinda.
has been a lie. And you're like, yeah, I'm really sorry. I had to be a person to tell you.
Yeah.
Give them autonomy while also like doing harm reduction. So.
Yeah. Yeah.
I would also just throw in there in terms of how to reframe it in the moment with that kind of commentary is that one of the biggest things we can do in whatever role is be allowing the space and acknowledging that you hear them and giving them that safety that you're a safe person for them to share that, and just listening and not always having to have the answer because they are the expert on their own experience. So we don't always have the answers.
We often don't.
I think referring to people in fat bodies that have those lived experiences and how they deal with those situations is often the best answer to me.
Yep, for sure. Any other questions?
I also wanted to remind everyone on those note cards, please throw down some ideas for anything that we talked about that you want more of for our future presentations. There was like 3 or 4 topics in particular. We're going to collect those too. So if you care to do that.
Yeah.
Can you talk more about your experiences with eating disorders?
Ooh.
In this topic?
In this topic, yeah, I mean, I think it's hard. So within eating disorders and eating disorder care, typically we see it in, again, the social norm is like, it's a thin white disease. It's like not necessarily actually BIPOC communities are going to be typically in larger bodies and struggle more because of societal trauma and overall body trauma and things like that, struggle more with disordered eating, specifically within particularly more like binge purge or bulimia, but also like we even hear like it's so stigmatized and even have the diagnosis of atypical anorexia. Atypical meaning that it's not meeting this low BMI category, but it's like I've had patients before where it's like they don't fit in a low BMI category, they're in fat bodies, but what they're eating is praised by their doctors, like, oh, you're doing such a good job. And I'm like, nope, absolutely not. They have an eating disorder and they're severely malnourished, and this is why all these things are happening. So I think definitely like eating disorder care and things like that, it's a big topic, but all of this of like looking at how do we screen, what are some best practices, what are things we need to look for, that's going to be a big conversation because I think we've all identified this is a big topic that we don't know a lot about. And honestly, about 10% of the population has an eating disorder. So you probably know someone who's had an eating disorder. You've definitely worked with people. So really looking at how do we come from a trauma-informed space around this to make it a safer place for all people. And there's also eating disorders, but then there's disordered eating, which is kind of the same. It's just not fully diagnosed.
Wonder how like underrepresented that statistic is too. 'Cause like
Oh,
you said,
deeply.
When was the
Because
last
the
time you were
DSM
screened?
criteria is also
Deeply.
so
Yeah.
Yeah.
narrow-minded.
Yeah.
Yeah.
And primary care doctors are not screening for eating disorders.
Totally.
Just telling fat people to eat less.
Yeah. Yeah.
It's helpful.
Was that kind of,
Well, yeah, that's the next idea.
yeah,
That could
yeah.
be a whole
It could be like a series of like, and we're gonna like interact, and like, and yeah, but yeah, and I think too, it's just looking at that a lot of disordered eating disorders is really just looking for safety a lot of times. So looking at as a healthcare provider, like how do we provide that safety and not make this space where they're seeking care like very unsafe.
Right.
Yeah.
Not perpetuating it.
Yeah.
And that, and that starts with conversation, like basic things, asking someone, do you have access to food? What is your relationship with your body? These questions, what is your relationship with like movement and things like that? And yeah, even just starting there.
And even like if you have choice and autonomy as a provider of what's on your intake form, like making height and weight optional, making that not a required thing. Also asking like, have you ever had an eating disorder before? That's a pretty simple question that it's actually really surprising to see it like, oh, okay, cool. Like this actually a lot of people like, I don't know. And it's like, oh, you don't know? Then like, we're probably really struggling here. And I would say, honestly, most of our society and culture struggles with some form of disordered eating in one way, shape, or another. I've never met someone who has like a totally normal relationship to food, whatever normal is, because we don't know what that is.
Right.
Yeah, and movement too. Yeah.
Just like ask about their behaviors before assuming.
Mm-hmm. Yeah.
It's
Yeah.
a really good, easy place to start.
Yeah, I mean, and I think even too with the Novo Nordisk study, like I've had an increase in people who are on anti-diabetic drugs for weight loss. And a lot of times like their providers, like I had one individual who they were told to not eat beans and rice because they happen to be Hispanic and they should just stop doing these things. And like, he's like, I don't actually like beans and rice. And first and foremost, but B, like they were super nauseous and having a lot of side effects because they weren't educated on what are the side effects of this medication. And they were just told to lose weight. So they just weren't eating. And so there was like this crazy effect of this medication also with not eating. What do? We like increase frequency of food, and like they're thriving. Kind of simple. Cool. Great. Well, thank you all for being here. It's small and hot in here, so
Yeah.
we'll find a bigger space next time.
Yeah.
But yeah, feel free to reach out to us with any questions. You can follow us on Instagram. We are a collective, meaning that sure, like you see our three faces here right now, but if there's something you're like, I really want to talk about this, and I feel like this would be something that I want to bring forth to the community or like have a way of like, whether it's fitness or whatever, it's like we are super down with that and we would love to help facilitate that and like help you share whatever you want to share. So this is not just about us, it's about all of us together.
Thank you. And there are those handouts in the back if you didn't grab one or.
Yeah, there's snacks, handouts.
And there's plenty of snacks and water.
And if you didn't get a note card but want to write down a topic, you can in here. I have my topic.
Great. Can I hand deliver this? Yes, I love it. Oh, we'll just send it out by email because you should go.
The what?
Say when we have our next day planned already, but
Oh, yeah.
okay. We can email it out.
Introduce myself to Abby. My daughter's
Hi.
Megan.
Oh,
So she's like,
awesome.
you need to go to this and tell
Oh,
her I said hi.
oh my, I love her.
So thank you for helping her so much this summer.
She's
I
amazing.
know she shared with you
Yeah.
everything and Yeah, never thought this would be her.
Yeah.
And she's just really turned it around. So she'll be here next week for Thanksgiving, so she's already signed up for
Yes.
and
I mean, and it's so hard too. I mean, all of these things. Like I used to work in like substance use stuff and things like that too. And there's a big intersection. And I just think that like it's like in the world that we live in, like it's just so hard. And like in those spaces in community and college, like it's just difficult. So yeah.
I just want to let you know how much we appreciate
Oh,
you.
thank you.
And then I've sent patients your way. I'm an internist. So
Okay.
I deal with adults, like older adults.
Yeah.
And I don't focus on the weight so much. I usually say, well, what are your goals?
Yeah.
What do you want to, and I encourage activity more than anything.
Totally. It's the number one thing you can do.
Primary care, we just don't have the tools, right?
The tools are often time. Yep, totally. And I think, yeah, to have these big conversations of like, what's your relationship to food? You're like, cool, I got like 5 more minutes and I gotta go. So I think it's hard from like a structure standpoint of how we structured the system is a little difficult too. Yeah.
So you don't take insurance at all? It's just
We don't take, it's just cash, but I will do sliding scale if people are interested in that. And we will also write super bills so it can go towards our out of network or things like that, just to cover the insurance. And we also accept HSAs.
Okay.
So there's
Do you
workarounds.
have like an email that I could email you if I had a patient
Yes,
to send you?
totally.
Okay.
Yeah.
On
Let
the
me.
Evolve website.
I think I probably hit it, but I'll give it to you personally. Or do you want me to write it down?
Just write it down. I kind of follow the obesity code. Have you read that book by Jason
No.
Fay?
I don't think so.
It's really good. And his whole point is it's not so much, when we're eating, what we're eating is when we're eating. And so I usually just try and keep it super simple for patients, because my patients are typically over 50.
Yeah. Yeah.
Like simple things like eliminating processed food is probably like a really good place to start increasing your activity. Megan has taught me a few things. She's like, you can't be so restricted. So I've really tried to back off on, you should avoid dairy.
Yeah, well, and also too, I like to think, and I found a lot through like a lot of just like work and fumbling through a lot of these things, like earlier in my practice, of like people do really well with things that we can add. So being like, could we add like a fruit to your breakfast, or could we add a vegetable at like 2 of your main meals? So think of adding, because then also like theoretically takes up more space and we're getting more nutrients in, or it's like things like that. Yeah.
Anyway, it's good to finally meet you.
Oh,
She's
it's so
talked
nice
about
to meet you too.
She's got me going to the foundations class.
Nice.
We just started. Yeah.
Nice. Oh, well, welcome.
All right, yeah, I'll see you around.
It was nice to meet you.